Welcome back to Refrigerated YouTube videos. In this video, we'll be covering the hepatitis B serologies, and we will make them fun, okay? I can tell you at points in learning this material, I have been just completely lost. I've been bluntly memorizing them, and it's not been very memorable to me. This video is dedicated not only to us being able to excel on our exams, but for us to really make accurate decisions when presented with patients in real life, so that we can say we are from the Ohio State College of Medicine, and we are astute clinicians, and we know exactly what we're doing when we get these hepatitis B serologies, okay? So that's really what this video is donated to. And you can see here, we're really moving up in the world. We're not even writing on refrigerators. We even got our mascot here saying go Bucks, and I'm really excited to present this to you. And just as a quick overview, we'll be going over different mnemonics, step one, and then we'll give a couple different examples of those mnemonics, and then I actually have practice problems that we're going to go through together. And then, if you really would like to stay, I'm going to tie in some board relevant step one material at the very end with 2 extra slides that I really think will help not only bring in the early 2 weeks of this host defense block, but also some GI renal. So I'm excited to present this to you. Can't wait to get started. Let's get going. Alright, so first, I believe if you can get down these hepatitis B mnemonics, you can solve any problem given to you or any patient serology handed to you when we're on the wards, okay? So really ingrain these into yourselves, and I believe that they will be very, very meaningful for us to do, okay? So, first, okay, the surface antigen, okay? The surface antigen. The mnemonic for that is the S in surface goes with symptoms, okay? So if you have a patient and they have positivity to the surface antigen, that tells you the patient has an acute or chronic infection present, okay? The surface antigen, the mnemonic is symptoms, because you have symptoms in acute or chronic infection with hepatitis B, and so it tells you that there is an acute or chronic infection present, but it does not tell you if it's acute or chronic, okay? And you're probably thinking, whoa, wait. Well, let me tell you what's next. All right, so the core antibody. The core antibody is what tells you chronicity. The C in core tells you chronicity, okay? This is so key. The core antibody tells you chronicity, okay? And what is the first antibody produced by B cells? That is IgM. IgM is the first antibody produced by B cells, correct? So if IgM is present, the core antibody IgM, if it is present, along with a positive surface antigen, that tells you you have an acute timeline, an acute hepatitis B infection, okay? But as we know, as B cells get smarter, they undergo somatic hypermutation and affinity maturation and all that jazz. And eventually the B cell class switches, right? The B cell class switches to IgG. IgG is a marker of a chronic timeline. That tells you the infection is now chronic. The B cell is no longer creating IgM. The first antibody it produces has got smarter. It has undergone class switching, and now it is producing IgG, okay? So if you have a positive surface antigen in the setting of a positive IgG core antibody, that means that you have a chronic hepatitis B infection. And I really want you to get this ingrained in you. The core antibody is chronicity only. It's timeline only. It tells you the timeline, chronicity. The surface antigen tells you if there's an acute or chronic infection. Surface antigen, infection, core antibody, chronicity. Okay, that is such a key concept, okay? And you're probably wondering why the core antibody and not the antigen, okay? So the core antigen actually cannot be clinically detected in the serum, okay? That's why it's the core antibody, okay? All right, so the E antigen, the other major antigen, the E antigen, I like to think of the E as in emails. And so you're sending out emails to people and they're not responding to you. Keep sending more emails. Pile those emails on. 50, 100, 1,000. Send more emails. The more emails you send, the more likely you are to transmit your message, right? So in the same way, the E antigen is the marker of transmissibility and infectivity. The more E antigen you have, the more emails you send, the more likely you are to transmit that message. It is a marker of transmissibility and infectivity. All right, and here's just a little diagram over here to refresh us on where the surface antigen is, the core antigen, and the E antigen. All right, so one special case to what I was just talking about. This is called the window period, and this is a lot, so just kind of listen. We're going to go through this slowly together and make sure that we really understand it. So on this slide that we talked about how the surface antigen must be present to mark an acute or chronic infection. Surface antigen, symptoms, infection, right? Well, there is one special case called the window period. This is when the surface antigen is actually negative, but there is still an infection with hepatitis B going on. How is this possible? All right, so let's look at this slide right here, this diagram. Okay, and look right here at the virus shedding, and it is the surface antigen here in the dark blue, and as you can see, as it's going down over time, okay, you can see at the same time the anti-surface antigen antibody is increasing. And look at this. At this stage here, at this stage, they're basically in a 1-to-1 ratio. And so they're complexing together. So if you measure a person's serum, you can neither detect the hepatitis surface antigen or the anti-hepatitis B surface antigen antibody. They have complexed together. Neither one of them will be present in the serum, so to speak, because they'll be complexed together. They will be in a window period of being gone. They will be gone from serum. And that is called the window period. And that, as you can see here, is when they are basically in a 1-to-1 ratio together. So let's read together here. The key concepts. Antibodies to the surface antigen are an equal concentration to the surface antigen, forming immune complexes, so it appears that the antigen, and it should say the antibody, have vanished from the serum. Okay, so how are you going to diagnose in a vignette or in a serology that the patient still has a hepatitis B infection going on and that you are indeed in the window period? Well, this is the situation where the core antibody comes to save the day. Okay, and if you look over here, the core antibody, at the same time this window period is approaching, the core antibody reaches its peak. Okay, so if you see that the serology still says that the patient has a positive hepatitis B core antibody, then the patient is still infected with hepatitis B and we are in the window period. And you might be looking at this chart going, well, why don't we just use the anti-hepatitis E antibody? Why don't we just use the E antibody? Well, look at it. It doesn't rise as much as the core antibody. Do you agree? So, since this rises less than the core antibody, there's more room for error. It's less detectable. There's more room for error according to the research that I did. And so the core antibody rises to a higher degree in the serum and is a more reliable test with less margin of error. So that is why you need to look at the core antibody to determine if you are indeed in the window period. Okay? Very fun, right? All right, let's go on. So, how do we approach the problems when we're given these in vignettes or we're given serologies and we really have to solve them? I want you to start at one single place, okay? And this is where I start. I look at the anti-hepatitis surface antigen IgG antibody. Look at the surface antigen antibody, okay? The surface antigen antibody. That is the marker of immunity, okay? So, excuse me, as we're going to go through these two branches here, but just as an overview, if the surface antigen antibody is present, that means the person is immune to hepatitis B, okay? That means the person is immune to hepatitis B. Really ingrained that concept, and now we're going to go through a couple cases together. Let's start here on this side first. We're going to start with the positive one. Okay, so in a positive, if the patient does have hepatitis surface IgG antibody positive, that means two cases. Either they're a vaccine responder or they've been exposed to the infection before, okay? And I'm just going to pull up this diagram to explain the vaccine responder. This is all of us, basically. Okay, so the vaccine that we were given to go to medical school or just, you know, as a routine medical appointment or whatnot, the hepatitis surface antigen is the only component in the vaccine. Okay, and that makes perfect sense because look at the virus, okay? The outside of the virus would be the first thing that our immune system sees. So it makes logical sense to give us the surface antigen so that our body would first recognize the outer coating of the virus. That makes perfect sense. So the vaccine only contains this surface antigen, and thus we only form the anti-surface antigen IgG present. So if you get a case and the only thing that is present is the IgG surface antibody, then you know that person was a vaccine responder and they got their vaccine. That's all that means. Yay, Beverly Charles happy with us all, right? All right, so if not, now let's say this is another case. Now what if the surface antibody is positive, okay? What if the surface antibody is positive, but they also have the core and the E antibody positive as well? Okay, well, this tells you another thing. This tells you if this component here, the core and the E antigen, along with the surface antigen are positive, all three of these are positive, it can't be because of the vaccine. That means that person actually was exposed to the real deal, the rip-roaring virus itself. It was exposed to the bad guy, all right? That means to form those antibodies, the core antibody and the E antibody, that means they are actually exposed to the virus itself. And so that is the only condition that you would see a positive IgG antibody and the E antibody and the core antibody. That tells you that they are actually exposed to the virus itself and that they won the battle. They formed the antibody, the marker of immunity. They've won the battle. They are now immune to hepatitis B. Okay, now let's go on the flip side. What if they have, what if they're negative for this antibody, the surface antibody? Well, say they come in, they say, you know, we're going to Beverly Trout. Hey, Beverly, you know, I got my vaccine. Here's my documentation. I put it in Castle Branch. You know, I got my serologies drawn, and man, I'm negative for the surface antibody. Well, that means that you are a vaccine non-responder because the vaccine, again, only contains the surface antigen. So if you didn't form the antibody, you're a vaccine non-responder in the setting that you actually went and got your vaccine and did not respond to it, okay? Another situation in which the antibody is negative, okay, the surface antibody is negative, is if a acute or chronic infection is still present. Right, and that just makes intuitive sense. If there is an acute or chronic infection still present, which would be marked by the hepatitis surface antigen, if we're not in the window period, of course, that means that the person is not yet immune, right? If there was an antibody formed, the antibody would complex with the antigen and it would no longer be there. So if they have a negative surface antibody, that either means they're a vaccine non-responder or they still have an acute or chronic infection present. And we're going to apply all these concepts now to a table that I made, and these are our practice problems, okay? So you're going to just come in, just make up a general person in mind. You have an IV drug user that comes in, and you're really sure that they have hepatitis B. They just have the clinical presentation of that, okay? So again, start with the surface antibody. There's no surface antibody, okay? So that means they're a vaccine non-responder or they still have an acute or chronic infection present. And I like to go from the surface antibody to the surface antigen. I think these are the two most important things. So my eyes always go to the surface antibody first and then the surface antigen. If the surface antigen is positive, that means an infection is still present. Okay, surface means symptoms. That is the marker of an acute or chronic infection. How do you know if it's an acute or chronic infection? Go to the core antibody, which means chronicity. Core means chronicity. The C is chronicity, and it's IgM. That means the B cells have not yet undergone class switching. That means we're very early in the game. That means this is an acute infection, okay? And you might be looking, well, what does the E antigen indicate? Well, if the vignette gave us a certain amount of the E antigen present, that could tell us its transmissibility. Remember, emails. The more emails you send, the more transmissible it is. The E antigen is a marker of transmissibility. So if it was a higher level here in this acute infection, we know that this person is very infective to others, and that is exactly what the serology panel would tell us. Okay, so let's go on to this one. I start here with the surface antibody, and it is positive. The surface antibody, IgG, is positive, and everything else is negative. So that is all of us. We are vaccine responders, hopefully. So that means that we all got the vaccine, and the vaccine only contained the surface antigen. Therefore, we formed the surface antibody to that antigen, and therefore we have positivity to the surface antibody, and we are immune from the infection. Okay, from hepatitis B. All right, so let's go on to this third case here. Okay, we start here with the surface antibody, nothing there. So we look here at the surface antigen, and it is positive, and that indicates that we do indeed have a hepatitis B infection present. Okay, and now we go over to the core, the chronicity antibody, and it's IgG. That means that the B cells have undergone class switching. That means we're later in the game. It's now a chronic infection, right? Because the B cells have already undergone class switching, which takes time. Now we're in a chronic infection, okay? And so let's revisit the E antigen, and now let's address the E antibody in this problem. Okay, well, if it's positive and at a high value of the E antigen in the setting of a chronic infection, that means we have a high infectivity, right? Nothing new, okay? So let's compare this right now to if you have a negative E antibody. That does indicate they have a higher infectivity in the setting of a chronic infection, right? Right, and that just makes intuitive sense. If you have the antigen, the E antigen still present in a high amount, and you have no antibody to it, the E antibody is not present, that would mean your body has not formed the correct immune response against the pathogen yet. You haven't formed the E antibody. It's still a rip-roaring infection, and that means that you're still at risk for high infectivity, right? If you haven't formed the antibody, the E antigen is running amok, you're still transmitting that email to all the different people, and you're very infective to those around you, okay? And the converse is true if you have a negative E antigen. If the E antigen is really low, you're not sending in much emails, you're not as infective to others, and hopefully you form the E antibody. If the E antibody is present, it's complexing out those E antigens, and you're no longer as infective to those around you. Okay, very cool, right? All right. So let's go down to this fourth case. All right. So I always go to the surface antibody first, and it's positive. That means I'm either a vaccine responder or I've overcome a hepatitis B infection from the virus itself. Okay. So we look here in this setting, and we have a core antibody positive, and we have an E antibody positive. Well, that means that we have beat this infection. Okay, because the only way that we can be exposed to the surface antigen to form the surface antibody, the E antigen to form the E antibody, and the core antigen to form the core antibody is if we are exposed to the real deal itself, the virus itself. Those are the only way we can have those three components be present in our serum and form antibodies against them. Okay, so this means this person has overcome their infection from hepatitis B. Last problem. We look here at the surface antibody. We look here at the surface antibody. It's not present. Okay, we always go over here to the surface antigen. It's not present. But this person really seems like they have hepatitis B. Say it's a pregnant mom who has a very high level of E antigen. Say it's a pregnant mom in acute infection stage. So it's a pregnant mom in acute infection stage for this case. And you're really thinking, gosh, I really think that this mom, when she has her baby, now say the baby's born, I really think this baby might have, a hepatitis B infection, okay? Well, I know that was a roundabout saying it, but think about it. You would need to look at the core antibody, right? This might be that window period where the surface antigen is negative and the surface antibody is negative, meaning that the surface antibody and the surface antigen have complexed together and have essentially, quote unquote, vanished from the serum, even though they're just in a 1-to-1 ratio, and it appears that they have vanished, right? Like Schrodinger's cat or whatever. All right, so they're both there and not, right? No. So the core antibody is where you want to go, and if the core antibody is present, that's your saving grace. And remember, you want to use the core antibody over the E antibody because the core antibody is present in higher levels, so there's less room for error. So since the core antibody is present, and along with the E antibody, that's supporting case that we are indeed in the window period. And sorry to go through that little vignette about the pregnant lady. I'm just trying to emphasize that you might get a vignette where it is just stone cold. This has got to be hepatitis B. And you look at the serologies, you don't have the surface antibody and you don't have the surface antigen. Really look for that core antibody or E antibody. And that'll tell you actually do have a hepatitis B infection, okay? So you can quit the video now. Those are the hepatitis B serologies, but I added 2 quick slides here on the end to really talk about the rheumatology section of this block and the GI renal block to help get us prepared for our step 1 coming up. So if you want to join me on those, follow me to the next slide. If not, go Bucks. Have a great day. All right, so the pathophysiology of polyarteritis nodosa, okay? Now we're going to talk about those immune complexes, right? So I believe this disease, I was just finding myself memorizing it, and I hate memorizing things. I just got to find an intuitive way to remember this and make it fun. So all medicine and all school, you just got to find a way to make it fun for yourself, and finding it fun for myself is making a mnemonic. And my mnemonic is microaneurysms can be fun. Get it? Like can be fun? Well, it's funny to me at least. So microaneurysms can be fun. Okay, and all of this is encompassing the manifestations of polyarteritis nodosa. So in polyarteritis nodosa, remember you get those strings on a bead, you get those microaneurysms forming, as you can see here in this arteriogram. You can kind of see those there. Okay, and the PAN stands for polyarteritis nodosa. So PAN B for hepatitis B. So polyarteritis nodosa, PAN B. And the fun, you might be wondering, what's fun mean? The F in fun means fibrinoid necrosis. Okay, so polyarteritis nodosa is a necrotizing vasculitis. It is a necrotizing vasculitis, and PAN B fun reminds me that it causes fibrinoid necrosis. So we look at this histological section over here. We can see some of these purple dots in here indicating that we have an immune process going on, right? That is because the surface antigen and the surface antibody have complexed together, and now they are, embedding themselves into the medium-sized blood vessels. Kind of look at this blood vessel. It's not a large blood vessel, nor is it a small blood vessel. There's plenty of a muscular layer here, a muscular coat. So this is more of a medium-sized vasculitis, and we know that not all medicine follows the textbooks. It can be small, but it's really a medium-sized vasculitis, medium blood vessel-sized vasculitis. Okay, and so you can see here how you have that fibrinoid necrosis, that really eosinophilic, hyaline-looking material in the blood vessel, indicating that you do indeed have a fibrinoid necrosis. Okay, so fibrinoid necrosis, I want you to think of PAN B fun and think of hepatitis B and polyarteritis nodosa. Okay. So now I want to go through kind of the manifestations of polyarteritis nodosa, and I want to make them intuitive, okay? So think about it. What is a large blood vessel? A large blood vessel would be like the aorta, right? That would be obviously a large blood vessel. But what would be medium blood vessels? Well, think about it. That'd be like the brachial artery, right? The brachial artery could be a medium blood vessel. It is, in fact, a medium blood vessel, and so are kind of the radial and ulnar arteries, right? And so if you're forming these immune complexes, like over here, and you're plugging up those vessels with all that fibrinoid necrosis, well, you're not going to get blood flow, right? You're not going to get blood flow as efficiently through those vessels. So what does the radial and ulnar artery supply? Well, they supply the radial nerve and the ulnar nerve, respectively. And that's how you get that poly or mononeuropathy. That's how you get that wrist drop. If you're not supplying adequate blood supply to the radial and ulnar nerves, then you get that neuropathy. You get that wrist drop. That makes intuitive sense to me. Okay, so let's go on to this next point, okay? And we're going back to GI renal here, okay? Remember off the aorta, there was this testicular artery, right? And that was very interesting. It came off the aorta, and it's a medium-sized blood vessel, right? Because it's coming off a large blood vessel, becoming a medium blood vessel, and that is the testicular artery. And that's why, if you remember in class, we learned about that patient who came in, and they had like testicular pain and tenderness and numbness in their scrotum. Well, that makes sense, because the testicular artery is a medium-sized blood vessel, and again, think about that fibrinoid necrosis. It's just clogging up that blood vessel. It's not getting adequate blood supply. Therefore, you're going to get this testicular pain and tenderness, okay? And you ladies out there might be wondering, why isn't he talking about the ovarian arteries? Oh, yeah, those are medium-sized blood vessels, aren't they? Yes, but I did that on purpose. And I did that on purpose because polyarteritis nodosa occurs in a 2-to-1 ratio. There are 2 men for every 1 woman affected. So this is really a man's disease, so to speak. I just did that for broad purposes because it's more of keeping that epidemiology in mind. But ladies can too get this polyarteritis nodosa effects on the ovarian arteries. Okay, so how about the skin? The skin isn't supplied by large blood vessels, right? It's supplied by medium arteries. All right, it's supplied by medium arteries. So remember that we had that interesting skin condition called livedo reticularis. That was really that lacy, cool-looking rash, and it can cause purpura. It can cause ulcers. Remember, the skin can do whatever it wants here. It's just those medium arteries going to it. So you get different manifestations depending on the medium blood vessels you affect and where you are in the body. Lots of variables going into that, so that isn't really a key point, but it is enforcing the fact that it's those medium arteries that are branches off the aorta, eventually going out to the skin through the small ones to lead to those manifestations. Okay, now here's where it becomes really fun and intuitive, I think, and that is with we're going back to GI renal again, the celiac, the SMA, and the IMA, right? Those are all coming off the aorta. They are medium-sized blood vessels, right? So think about it. If you do not supply the celiac, the SMA, the IMA, if you're clogging those up with the fibrinoid necrosis, right, you're not getting blood supply to the abdominal area and, more importantly, the intestines and the digestive tract, correct? So intuitively, you would have abdominal pain. That makes sense. If you're not having blood flow there, you're getting ischemia, which can lead to your abdominal pain. You can eventually, if you don't have enough blood supply, those cells are going to slough off, they're going to die, and that can lead to gut perforations. And again, if you're not supplying the gut with adequate blood flow, you're not going to be able to properly digest your nutrients and absorb those nutrients, therefore you're going to get weight loss. And so I just think that made perfect sense to me that celiac, SMA, IMA are all medium-sized blood vessels that can be affected by fibrinoid necrosis and polyarteritis nodosa, and then you would get the abdominal pain, ischemia, perforation, and weight loss. That just made intuitive sense and really a lot of fun. And then in muscles, of course, muscles just like those supplied by the brachial artery, you can get those myalgias and weakness and things like that. Okay, so how about the kidney? Well, remember the kidney, if this is the kidney, it has blood vessels going into it, right? Well, those blood vessels going into the kidney, right, those are medium-sized blood vessels. So that would give you a pre-renal azotemia. And all those alarm bells are going off in your head right now. You're thinking, but wait. I thought hepatitis B causes a membranous nephropathy, a nephrotic syndrome, right? Well, it can also cause pre-renal azotemia in the setting of polyarteritis nodosa, and that requires a slide on itself, and this is our final slide, so thanks for staying with us. All right, so hepatitis B kidney disease. Where are the immune complexes depositing? That is the big question, okay? If those immune complexes, the surface antigen and the surface antibody, if they are depositing themselves in the medium-sized blood vessels, that can lead to polyarteritis nodosa and necrotizing vasculitis, as we discussed. And this does not cause glomerulonephritis, right? Does not cause glomerulonephritis, but hepatitis B can cause polyarteritis nodosa. And polyarteritis nodosa, as we just drew on that last slide, if this is the kidney here, you have blood vessels going into the kidney. These blood vessels are coming off the aorta, remember? You have the left and right renal artery, and then it branches. Those those arteries there are medium-sized blood vessels. Those are medium-sized blood vessels. Therefore, you get a pre-renal azotemia, right? Because it's pre-renal. You haven't got to the kidney yet. Those medium-sized blood vessels off the aorta haven't branched into the small little blood vessels that go and form the glomerulus. We aren't even close to the glomerulus here with hepatitis B causing polyarteritis nodosa. We are in the medium-sized blood vessels. How in the world can we be in the little tiny glomerulus and those tiny little capillaries? We are before the kidney. We are pre-renal. Therefore, we get a pre-renal azotemia, where you have an increase in BUN and creatinine, and this is because of those immune complexes depositing in the medium-sized blood vessels before they go into the kidney. All right, so what findings would you expect here that rules that hepatitis B can be causing this pre-renal azotemia? Well, you would have a decreased GFR leading to hypertension, and we're going all the way back to GI renal. We can get those hyaline casts in the setting of a pre-renal azotemia. And just think about it. If you're not having adequate blood flow to the kidney, remember, if you're not having those medium-sized blood vessels supply blood flow to the kidney, how can you secrete sodium? You're not getting it to the kidney in the blood. Therefore, you're going to have a low urinary sodium, and if you calculate the FeNA, it'll be less than 1%. Great review, way to tie all in hepatitis B into this discussion. Really find that fun. Okay, now let's think about where are the immune complexes depositing. If the immune complexes deposit in the medium-sized blood vessel, as we just discussed in polyarteritis nodosa, you get a pre-renal azotemia. However, we do remember that hepatitis B can cause a membranous nephropathy. A membranous nephropathy. It causes nephrotic syndrome. And I like to just capitalize these two things right here. Okay, the B and membranous reminds me that hepatitis B is a cause of membranous nephropathy, and the S we'll get through here in a second. And just as a contrast, hepatitis C is more commonly associated with MPGN. Okay, just to keep that straight. Okay, so I got some diagrams for us to look at together. So hepatitis B, when it causes a nephrotic syndrome, remember with those Maltese cross, oval bodies, fatty casts, all that good jazz, all those protein waste things that we learned about. Okay, that in the setting of that vignette, okay, you might get a light microscopy and it could look like this. And why would they call this membranous nephropathy? Well, just look at it. It looks very membraney like, right? It's because those immune complexes are depositing in the membranes around the glomerulus, okay? So you get diffuse glomerular basement membrane and capillary thickening because that is where these complexes are depositing, okay? So that's what you would see in the setting of membranous nephropathy on light microscopy, okay? And so if we do immunofluorescence, of course, we're going to see the hepatitis surface antigen and antibody complexes. They're going to be lighting up like crazy on the immune complexes. And just look at this. The immunofluorescence looks very similar to the membranous, right? If you go back and forth between those two, you can really see the correlation between the membranous looking light microscopy and the immunofluorescence. Okay, very interesting. Okay, and here's where that S comes in that mnemonic, is that the S reminds me of the spike and dome. So membranous nephropathy causing nephrotic syndrome. That S capitalized and bolded here reminds me of the spike and dome appearance. And I didn't use an electron micrograph here. I like this diagram because it really, I think, showed me that I can see the spike and then the dome, the spike in the dome, the spike in the dome, okay? And that's how I keep straight that the membranous nephropathy, I think I keep wanting to say glomerulonephritis, the membranous nephropathy caused by hepatitis B can lead to a spike and dome appearance on EM, okay? So I think that was a nice way of wrapping together hepatitis B in terms of our rheumatology block, in terms of our GI renal block, and really helping us get prepared for our boards and kind of review some high yield material. So thank you for staying with me.